Following is a conversation with Professor Brendon Stubbs. Brendon has dedicated his career to studying how physical activity shapes our minds. Ranked in the top 0.1% of researchers globally, his work has transformed our understanding of how movement and exercise influence mental illnesses like depression and the relationship between our bodies and our minds. Welcome to Bridging the Gap.
So we know physical activity is great for our mental health, that exercise is a really good thing to do, but how often do I actually have to exercise and what do I need to do? Do I need to be on a 12-week periodized program with a PT, or can I go for a walk twice a week?
Great question. I think that's like a really personal thing. So I think if you're somebody who's already doing a bit of exercise, that'd be different from if you're somebody who's struggling with their mental health, has a mental health condition. I think if the good news is that if you're not doing much physical activity or if you're struggling with your mental health, just doing something to start off with is like super important. So if you're not very active and you're struggling with your mental health, like starting off with like a 15-minute or 10-minute walk is like super important to get going. But if you're somebody who's already like regularly like moving, then that would be a bit more. So like the World Health Organization or like our European guidelines recommend that you build up to like 150 minutes over the course of a week, including 2 strength days training. But if you are somebody who's not doing much or you're struggling, then just setting off in these super simple small chunks is like a super really important starting point.
Yeah, you say build up to 150 minutes. Does that mean if you're doing under 150 minutes, you won't feel the benefits?
Absolutely not. These are like guidelines, and these are like aspirational guidelines. Those like guidelines would have put me off at many time points during my life for lots of different reasons. So these are aspirational guidelines we should building up towards. And like our research and other people's have shown that just like 10 or 15 minutes of movement for people who are not moving, not engaging in exercise, not going in this type of environment will start to feel benefits early on. But we should be building up to these. These are guidelines to not put regular people off. These are guidelines to be building up to people.
And you say 10, 15 minutes of movement is a good place to start. What kind of movement? Does it matter? Is it better if I walk opposed to run, or if I run for 10 minutes opposed to walk for 30, or is even that in itself overthinking it?
Overthinking it.
Yeah.
So like I think if I'm speaking to most people who are active, so if we go strip this right back, 80% of adolescents don't meet those guidelines of 150 minutes or 300 minutes per week. 50% of adults don't. So if I speak to that portion, which is a majority, just doing something is like super, super important. And we know if we look at the longevity of people who engage in movement and exercise for a long time, it's people who do something they enjoy and people who find something that is like social and like fun. So like I would say go to those people, go and find that thing. Like if you want to go and work out in a CrossFit gym, you want to go and walk, you want to go and take in park run, go and find that thing for you. And that is like super, super important, and then build up from there. We don't want to overthink it too much. So if I speak to the majority who are not doing it, particularly those who are struggling with their mental health, that is like a super important starting place. And then if we go into like people who are doing something, then we start to see some differences if it's like resistance training, strength training, HIIT training, yoga, Pilates. But for the majority, just doing something is like super key.
Cool. Can you speak to those differences a bit? So, okay, if now we've managed to turn up to the gym a little bit more, or we've started our walking, we're on our way towards that 150 minutes. And you said then maybe it slightly matters, or it starts to matter whether you're in the gym or whether you're walking. What should people start looking to do then as they get a bit more momentum going and they're starting to exercise and move a little bit more?
So there's a couple of things. So I'd say start to build up the time. So total time, more time is generally better. But one thing that we want to be careful of is like more time is not always better for your mental health. Maybe we can touch upon that a bit later. Build up time and also build up intensity. So by that, what do I mean? So the harder that you work your heart and lungs and harder that you work your muscles. So heavier weights, longer time that you're working your muscles, and also higher intensity. Build that over time. But we also see this intensity paradox. So particularly as we're struggling with our mental health, so the harder that we work, the more benefits we see for our mental health, but also the harder it is to get going, the harder it is to sustain. So it's a careful balancing act. The harder that we work, yeah, we see greater benefits, but it's harder to come back to. Not many people like thrashing themselves, particularly early on, in terms of the intensity. So come back, dial it down, build up slowly, both time and intensity. How hard you're working your heart and lungs, and also how hard you're pushing your muscles.
Does it ever diminish or plateau? So you said the harder you work, Typically, you might see more benefits the harder you train your muscles. Is there a plateau at all, or like at any point does that become negative? Are there ever diminishing returns over how often you're going to the gym or exercising for your mental health?
Totally.
Yeah.
So what we tend to see for most people for protection and also for a treatment, around 300 per minutes per week. We see over the course of a week, we see increasing returns. Around 300 minutes, we see like a flattening off, and then we start to see a decline for people going over. Now, if you're training for an event, or I don't know, like a marathon, a super marathon, or like a CrossFit event, or something similar, then like you can justify that. But for most people, including like elite athletes, they don't want to be training 300, 600 minutes per week. And then we see like a leveling off and a decline for people's mental health too.
Yeah, around 300 minutes. Um, Going back to that individual who might be struggling to start, so the prospect of 300 minutes or even 150 minutes is way off. What advice would you give to them to start? You spoke earlier about finding something you enjoy. How do you explore that? How do you find something you enjoy?
Well, I think most people that I speak to, particularly young people or even like people in their 30s, 40s, 50s, just think the whole concept of exercise, like just the word can be like really off-putting, saying like that's not for me. Most people have had really rubbish experiences, like if we think about the UK context or Western context of physical education at school, so like PE.
Yeah.
And often it's like the case of you must do this. You're all going out to play rugby today. If you're a girl, you're going to play netball today. It's very gendered and very you're going to do this. So most people just think that's it. I'm tapping out. So kind of like what we want people to do is refine the movement that they want and go and explore, go and have fun, like go and do yoga, Pilates, like netball, whatever you want. Go and find that thing, and then you're much more likely to go in and do it. And that's really like a good adventure for people to go and do. So kind of like unlearning, and also like readdressing that exercise is one thing, but really reframing that, because it really, when we look at guidelines, is any movement that you enjoy. So physical activity is any bodily movement, increased energy expenditure. So it doesn't have to be like structured exercise and go and find that thing, and you can go and have sort of fun within that sort of pursuit too.
I love that approach as well of not overthinking it. I feel like I see so many people in the gym who are worried about what creatine to take or protein to have, or whether they should eat immediately after the working out, how many times they should go, and what you're saying of no, just aim for the minutes, aim for those guidelines. Um, on that, on those guidelines of aiming for building up to 150 minutes, 300, what how did you find that out? How did science work out that those were the numbers we should choose, that the World Health Organization should employ as our recommendation? Why is that the best amount of time to aim for?
It's always a balance between what can we recommend for like public health benefits and what can we not scare people off. Most people are scared off by that number, like 80% of youth.
Yeah.
And 50% of adults are not meeting those. But also it's the base, which there is like a good amount of evidence for physical and also mental health too. So we know that we can continue to recommend benefits up to 150, even 300 minutes. We can't justify it for physical and mental health beyond that. So that's just what the consensus evidence of like randomized controlled trials, like observational data shows there is like the best evidence.
Randomized control trials, observational data. Can you speak to that a little bit? Can you explain maybe what they are and an example of that kind of study that has produced this sort of evidence?
Yeah, so like there's a lot of junk terms in there that's just like confusing for people. And so like observational data is where we look at big numbers of people and we observe them over time. So I'll give you an example. So like we've observed people over time looking at how much physical activity people do and the risk of depression in the future. And the good thing about observational data is that you observe people in their natural environment and you see what happens over a long period of time. It's cheaper and it's easier to do over time. And we looked at sort of 260,000 people in a big pooling of data over time, young people, middle age and older age adults, and said, if you engage in physical activity over your typical week, and we adjust for other factors at baseline and we follow you over like a 7.5 year period, what's your risk of developing depression over time? And what we do is we can look at big data for people all over the world, and we look at this endpoint, depressive symptoms or depression in the future. And within this like huge cohorts of people, we see that people who engage in regular physical activity are around 15% less likely to develop depression in the future. And if we bring it back to that number we spoke about, 150 minutes over the course of a week, that risk of developing depression drops by around 30% in the future. So this is observational data, but that's great because you look at big numbers, you look at people all over the world, all ages, but it's also noisy in terms of
Yeah,
the
what's the
data.
limitation?
Yeah, the limitation is lots of other stuff happens in people's lives. So we can look at the direction of that data, what happens for this future event, but we can't rule out sorts of, other factors going on in people's lives. In order to do that, we need to do what we call randomized controlled trials. And that is where essentially we get a group of people and we randomly allocate them, in this instance, to the exercise, and then we randomize the other group to usual care or doing like a light form of physical activity. And then we carefully reduce biases and we give people structured exercise over a 12-week, 16-week period. And we know exactly what they do to the best of our ability, and we adjust for other what we call confounds. Again, you're introducing another term. And then we can look at outcomes, and we can look at something like a cause and effect. So is it the exercise that's reducing people's depression, not due to natural variations in data? And again, that shows that when we do structured exercise to people with depressive symptoms or depression, young people, middle age or older age, we can help reduce the symptoms of depression or anxiety and other conditions too.
I wonder if you could speak to maybe some slightly outdated data, but I think it's super interesting about some of the randomized control trials around forced sedentariness. Firstly, I wonder if maybe you want to explain what that is, and then also what these trials did and what they found.
Yeah, so super interesting. We've been really interested in what happens when people are not moving, and there's been a few randomized control trials that have looked at like this enforced sedentary behavior. Thankfully, there are like healthy people with no physical or mental health condition, really trying to understand how does this impact our minds, because there's observational data showing this is not particularly great. Going for those reasons in order to say, is there a cause and effect relationship between sedentary behavior and poor mental health? We need to do a randomized control trial. So like two super interesting early ones, which are over 10 years old now, both in early 20s, young people, no physical and mental health condition, playing regular sports. And what the first one did is they said, stop moving, no more sedentary behavior and stop playing sports, randomly allocated those for sedentary behavior. The other group carried on as usual, engaged with their exercise. And they looked at their mental health at the start and at the end. And they showed that this week of enforced sedentary behavior sees a spike in poor mental health and depressive symptoms particularly. And I think what's interesting is another study did this for slightly longer at UCL, where they also looked at like these in peripheral inflammatory cytokines. And again, what is that? These are these peripheral markers in the blood that can show that there is inflammation or low level stress happening within the body, which you wouldn't feel when you wouldn't recognize, but these have been implicated or raised in people with depression or to a lesser extent anxiety disorders too. So they're basically implicated in the pathophysiology. And what they did in the second randomized controlled trial is did it over a 4-week period, saw the same thing. And you enforce sedentary behavior on healthy people, people become stressed and more higher levels of depressive symptoms, but you see a higher peripheral inflammatory response. So we are seeing a cause and effect that enforced sedentary behavior is not good, but it's also showing us a pathophysiological signal that this is not just happening in the mind, but we're actually seeing a change happening within people's bodies too, that is also there when people have like clinical conditions too.
So is that what you mean when you say pathophysiological? You mean it's not just a chemical change in our brain, but there's something happening physiologically throughout the rest of our body?
Exactly right. Something is happening in the body, which also corresponds to what we see in mental health conditions there. It's not to say these people have mental health conditions, they absolutely don't. But when we see these mental health conditions, on average, people with depression, anxiety have this peripheral inflammation. And in these enforced sedentary behavior studies, we see a rise in this peripheral inflammation in addition to worsening mental health.
We've spoken a little bit about mental illness. I wonder if you could tell us a little bit about your time working as a physio on psychiatric wards. You spent some time essentially prescribing exercise as a mental health intervention, right, for people with psychosis. What was that like, and what does it look like to practically prescribe that as essentially a replacement for medication or therapy?
So I think it's been a wild ride in terms of the acceptability of this, because when I first come into a psychiatric ward in 2003, like even the consultant psychiatrist was like, why have we got a physiotherapist here who wants to get people moving and getting people in exercise? And that was partly, attitudes, but also the evidence wasn't really there. So I've been very fortunate to be alive when there's been a huge change and shift and acceptability of exercise as an intervention in mental health services. So that's been a pure privilege. Now, we're not talking about some wishy-washy intervention. It's now recognized as an important part of people's treatment. So huge privilege to be part of that. And I think like now, it's just a tremendous privilege to be part of that. And of course, it's hard. People, when they come into hospital, when they're an inpatient, particularly, they're really unwell. And, the things that we've spoken about so far, 150 minutes, getting people doing like a 15-minute walk, a 30-minute walk, these are really, difficult for many people who are severely depressed, severely unwell. And often it's a very low level, light intervention, particularly in early stage. But the great thing about working with people, inpatients who are very unwell, is you can really see a transition as people start to recover, and you can see great progress with people too.
So what would you have prescribed to, say, someone with psychosis or bipolar? What would your first line approach have been for someone like that?
It would be very low level activity on average. So I'd get people just trying to get out, go for a walk,
Just a
trying to
walk.
get connected with their body again. But
Yeah.
then, as said, we've done also research on people with like really poorly managed psychosis, and like a national psychosis unit where we've got actually high intensity interval training on exercise bikes, and we've run studies on people with very unwell. And people think, oh, they won't possibly do it, they won't engage, and then even from a cardiovascular viewpoint, it's not safe. But we've actually shown it's feasible, it's acceptable, and it can be done, and people will engage. Of course, it's hard and difficult, but that's often people's attitudes. It possibly couldn't do this with people who are severely psychotic.
Yeah. And is it as good? And when I say as good, I mean opposed to pharmacological intervention or CBT, cognitive behavioral therapy, other therapies. Is prescribing exercise as good as what is already accepted as the first line approach?
So I think the best area to like take that as an example is depression, where most of the evidence is for exercise. We know that depression treatment is like complex, and we really look at this as a menu of options. We don't want to say that exercise should replace a particular treatment, but it should be part of a menu of options for people. And what the effect size is, or in plain language, how good it is as a treatment
Is that what you mean by effect size? How good it is as a treatment?
exactly how good it is as a treatment on average. And we're always talking in averages. And what we can see is, generally speaking, it has a similar effect size. So it's similarly as effective on average as CBT or other psychological therapy approaches, and to a lesser extent with less robust data with antidepressant medication. And again, this is for people who are less unwell to mild to moderate depression. But there's an important caveat within that, because exercise is difficult to what we call blind, to show that if you're doing an exercise in a randomized controlled trial, it's difficult for me to blind you that you're doing exercise. So you're exercising. So this influences what we call the quality of the studies, and if people are blinded. And then also to do a control group, if you're doing medication, for instance, you can give people a sugar pill. It looks the same, tastes the same. So it's very easy to blind the person taking the medication, and it's very easy to blind the people assessing their mental health symptoms. Doing that in the context of exercise is very difficult.
It's harder to like prevent placebo.
Exactly. So when we look at what we call overall the risk of bias, so how good is the overall quality of the study, it's important to caveat that exercise has some limitations compared to very easily giving a placebo for medication. That being said, with that caveat in, for mild to moderate depression, we see similar effects. When we look at other conditions such as schizophrenia, it's really important to acknowledge this is not a replacement to any other type of therapy or medication. It's just part of an option of
Part of the menu.
treatments, part of the menu. And an important advantage of exercise compared to other treatments such as medication and psychological therapies, which are wonderful treatments, very important, is we know that the physical health of people that use mental health services is really drastically affected. Higher levels of cardiovascular disease, obesity. And one thing that we know that exercise is good at is for preventing and managing the physical health conditions too, in addition to the mental health component. That's why it's an important part of the menu of options for people with various mental health conditions.
You spoke a bit earlier about that acceptability. Now, having said the effect sizes, how good they are as a treatment is perhaps comparable to the rest of the menu, the CBT therapies, pharmacological interventions. Is there still quite a slow acceptance or uptake of employing these mental health interventions as exercise? Are GPs starting to say, okay, go for a walk twice a week instead of take fluoxetine or another antidepressant?
So we've had good movement on the research, and now we're into guidelines. So in the UK, we have NICE guidelines which recommend the best evidence for doctors and healthcare professionals to treat a certain condition, in this instance, depression. And we've got really good pathways for people doing CBT. There's access to psychologists and there's access to GPs for medication. We know that the evidence is there for exercise to mild and moderate depression. What we don't have is the paths for people to go and get access to that exercise. So gyms are often not accommodating or welcoming to people with depression or other mental health conditions. There are not recognised programs being delivered in the community. If you go and see your GP, if they recommend you to a certain group or class, that's often based on sort of luck or local knowledge rather than having like a continual sort of nationwide coverage where we do in other approaches such as psychological therapy. So we've got much more to do to get around to having the implementation of this evidence in practice.
Yeah. Okay, I see what you're saying there. So it's, even though we know it may work, the structure's not in place in order to be able to employ it. So what would that look like? We'd need a national approach to, instead of just, oh, you should go to the gym, now you're on your own to go and find one. We should have universal gyms that people that are struggling with their mental health can go to.
Yes, we want non-stigmatizing approaches that are welcome to people with mental health conditions, so access to them. And the reality is that even if we look at personal trainers and gyms, there's high variation in the training programs for people getting there. Most people don't receive any training on mental health, supporting someone with depression, anxiety, and also schizophrenia. And the reality is they're not always the most welcoming environments. So we need structural environmental changes, we need training changes, we need program changes, and we need accessibility changes, because also many mental health conditions can impact finances and the socioeconomic issues, and we need to address those particular barriers too for people. So if you look at CBT, for instance, for most people, although there are waiting lists, they get access to psychological therapy over time, but getting access to a gym costs money. There are other barriers that we need to address in addition to making it more accessible to people.
I want to talk a little bit more about the neurobiological mechanisms of what's actually going on. Why is exercise actually so good for us? What's going on in my brain when I exercise that makes me feel so good?
So I think like the academically honest answer from my opinion is there's a lot, and the reality is we don't know
Okay.
most of the things that are happening. So if you'd have gone back to the literature 10 years ago, 20 years ago, people would have just said, oh, it's due to like one hypothesis, often the endorphin hypothesis. And the reality is, if we look at the field, there are many mechanisms, and most of these have been described in rodent literature, which is helpful but doesn't always translate to humans, animal studies, and they haven't been done in people with mental health symptoms or clinical conditions such as depression. So most of this is borrowed from, animal models or literature which is directly implied from quote unquote healthy people too. But what we do know, looking at people who have a mental health condition or raised mental health symptoms, is lots is going on. So we and others have shown, for instance, you can improve hippocampal volume or hippocampal perfusion, a really important area within the brain, which is in the brain and helps consolidate memories and the processing of emotions.
Right.
We've also looked in young people, other emotional processing areas of the brain, such as the prefrontal cortex, which helps with impulsivity, and other emotional processing areas could also be stimulated within people. But there's other mechanisms like the gut microbiome is another area which we're interested in, and showing this is affected in these conditions, and exercise may have a role. So there's lots happening within the brain, there's lots happening within the body, and I also mentioned earlier about inflammation within the body and the blood. And this is raised in people with depression, anxiety, and exercise, particularly strength training, is very good at mopping up this excess inflammation. So the muscles contracting can help mop this up, whereas excessive aerobic training can actually contribute to this. So we think that is one of the mechanisms. There's also other things such as the release of BDNF, which is essentially like a brain fertilizer and helps the growth of new areas within the brain, new connections between areas of the brain. and new pathways to develop. Like this big fertilizer in exercise we've shown and other people have shown can help release with this. So there's lots happening, all these multi-system effects. But if we think about like this gym, for instance, part of the reason many people will come back is because of the social interaction, being part of a group, having part of a sense of community, and also having fun. And the social interactions too, and feeling good about yourself. So we can't neglect or negate these psycho and social mechanisms too. So really we think we know very little, but there's many mechanisms which are going through to contribute to why it makes people feel good.
I want to touch on BDNF, which you mentioned briefly there. What kind of exercise do I need to do to get that? You called it brain fertilizer. Can I do anything to get that?
So particularly aerobic exercise is very good for releasing a BDNF, and particularly over 30 minutes per session, we see like what we call short-term or acute releases of BDNF, but it tends to accumulate over 4 weeks or longer too.
Okay. And you said short-term accumulation of BDNF. Can you explain sort of what that means practically? What would be happening in my brain?
So lots is happening within your brain. All of the areas in the connection, the pathways are starting to light up and essentially work. The lights are coming on in key areas of your brain that make you feel alert, more conscious, happy. And then you're getting this secretion of this brain fertilizer during and after. And that helps consolidate these pathways and synapses within your brain. We often talk about an exercise, the use it or lose it principle. And we think if you don't keep using your muscles, you're going to lose it and they're going to reduce over size. That is particularly so as you age, but the same principle happens within our brain. And BDNF and exercise is a really good way to use your brain and to keep those pathways strong.
I want to change tack ever so slightly and talk a bit about a lot of people exercise in order to lose weight. It's a great way to do it, and equally, of course, that makes us feel better. Perhaps that's slightly changing now because of the introduction of GLP-1 drugs. So things like Ozempic and Mounjaros, these pharmacological approaches we can take in order to simulate feeling full so that we don't eat as much. How do you feel about the rise of utilization of these drugs? Is this affecting the implementation of lifestyle approaches, lifestyle changes, exercise in order to improve our mental health? Is that a good or a bad thing?
So look, I think in their intended use, particularly if we think about people with mental health conditions who are disproportionately affected by obesity, diabetes, metabolic syndrome, all these conditions these drugs were originally pioneered for, it's a good thing. This disproportionately affects this population. And also what's important, I think it really propels lifestyle psychiatry exercise to another level because you take these medications and the data shows that for people who stop them, particularly without embedded behavior change, i.e. new nutritional or new exercise pathways, tend to regain all of that weight and more once they stop. So it's super important to have embedded exercise, changes in nutrition happening during the course. And another important thing which the data is showing is that these medications often don't differentiate between how the weight is lost. So many people see changes in the scales and think, fantastic. But what the research is showing that up to 40% of that can be losses in muscle mass, which kind of makes sense, right? If you're having appetite suppression, you're not eating as much protein, you don't have as much energy, you're not doing resistance training, people are losing muscle mass and they're not aware of the muscle mass that they're losing. And most people want to lose fat, not muscle mass. And muscle is important for lots of reasons we've spoken about earlier on in terms of, our brains and our bodies. And we really want to embed exercise within people's GLP-1 journey so people have good muscles and good function and good longevity during the course and coming off.
So it sounds like what you're saying there is GLP-1 drugs, Ozempic, etc., aren't necessarily bad, and they're great for a certain group of people that really need them, but they need to be implemented alongside exercise. And if they're not, then you can lose a lot of muscle, and/or you'll need to use the drug forever, otherwise the effects reverse.
Exactly. And it could not only could it reverse, but it could be much worse than you started for some people because you regain all of the weight and some often more. But the weight that you're regaining is higher proportionally of fat than muscle. So we're having this new emergence of this thing. Again, it's a technical word called sarcopenic obesity. So essentially people who are becoming obese again, but they're becoming obese when sarcopenia means low muscle mass. So we're seeing people regain the weight, more fat, less muscle, sarcopenic obesity. And that means people are less like physically fit generally, less able to be steady on their feet, less able to do the activities that they want, but they've got more fat. And this is not good for the long-term health and longevity of the population.
And is that simplified? Is that just because they're not consuming enough protein?
Not consuming enough protein and they're not doing resistance training, and both, if we very simplify it, need to happen over the course of that to prevent the muscle loss, because appetite suppression drugs out there affects people's energy levels. Muscle mass is lost quick and it's hard to put on. Fat is also lost quick on these, but it's much easier to put back on.
Before we wrap up, Brendon, I wanna ask you about what you implement in your life. You evidently have a career full of evidence and publications that show how important exercise is for our mental health and our physical health. Do you practice what you preach?
I do, mostly, but I don't have compassion on myself when I'm not able to, because I think the important thing is just to not punish ourselves, because it's all about having enjoyment. So my life is very busy at the moment with young child and travel, so I'm not able to engage in exercise as often as I would, and that's totally okay. Whereas other times I'm able to go and exercise, a few times a week, and that is good enough for me. So sometimes I'll go and do an exercise session, it'll be 15 minutes, and I know that that is better than doing nothing. For me, just keeping in the game is super important. And when I'm traveling and doing other things, if I don't do it, if I'm tired, other things, then that's totally fine too. For me, I'm in this for sort of like the long term to protect my physical health and also my mental health. But there's been times when I've struggled to do it and I keep coming back to it.
Yeah. So for you, it's that, the approach isn't necessarily I must adhere to this 6-day per week plan that's really intense. It's more just this will help me feel better and live longer. So I just need to do enough to reap those benefits.
Absolutely. All of the benefits that I really focus on, which are the greatest benefits, are all beneath the skin level.
Yeah. Brendon, thank you so much for talking to us today. One thing we like to ask everyone before we finish is, what have you got planned? Have you got any projects you can tell us about? Can you give us a sneak preview of anything you're up to at the moment? What you're excited about?
So much excited about. I think some of the key things that I'm really excited about now is we really want to provide better lifestyle interventions for people with schizophrenia. So we're in the process of trying to finalize a grant that, like, they're in the final stages of developing lifestyle interventions with these GLP-1 medications to say, can we help people? And then we really want to get to the mechanism level of why does exercise help people with depression? We've done a great job, as we've discussed here, of changing the evidence base, saying, yes, this works. We need to do much more in the implementation, but now we really need to say why, what is happening, and we don't really have very good answers on that, and that's a big focus.
I understand you're in that process of grant applications. Can you explain at all what those kind of studies might look like? How are you going to find out why, and what sort of lifestyle interventions are you talking about that you're going to try and help people with schizophrenia for?
So one of the things that we're going to do is get people with schizophrenia, and we're going to get people who are overweight, obese, have diabetes, and then we're going to support them through lifestyle changes using digital means, GLP-1 medications, helping them support, their diet, their exercise over a long period of time, because this takes, a long-term change. And then when it comes into like mechanisms of exercise, particularly with depression, we're going to do all sorts of brain scans. And one of the things I'm particularly interested in is the potential role of creatine and helping boost sort of brain metabolism. And creatine is very important traditionally within exercise environments to improve power. But we also know that creatine levels are reduced in the brain in many psychiatric conditions too. And brain metabolism is affected in these conditions. So we're looking at, can we use creatine and exercise as an adjunct to get even better outcomes than looking at exercise alone. So there's some interesting studies looking in CBT where they gave people with depression in a randomized control trial CBT plus creatine versus CBT alone, showing that if you just give creatine to CBT, you get better outcomes. But we think that if you combine it with exercise, you may get even better outcomes, improving mental health and cognitive symptoms too. So those are some of the exciting things we're going to be looking at.
Creatine has been something rinsed by the gym bros for years to get bigger arms, but you're saying that this might be something we can implement as a mental health intervention.
Exactly.
Yeah.
And watch it here, we're going to try and find out.
Brendon, thank you so much. Thank you so much for chatting to us. I really appreciate your time. That was a fantastic conversation.
Thank
Thank
you.
you.